Hello everyone, my name is Chloe Weisman. I'm a distance learner from Massachusetts, and here's my case study. An 18-year-old female presented to an emergency room with polyarticular arthritis, which is pain in 5 or more joints, chiefly complaining of swelling and limited range of motion in left knee and right thumb. Patient was a febrile. She denied trauma to the joints, had no exposure to ticks, and denied sexual activity. She had traveled to Mexico 1 month prior to the onset of symptoms. 2 weeks prior, she initially presented to an outside hospital with body aches and acute pain in her left arm and leg. She was diagnosed with cervical radiculopathy, which is an inflamed or damaged nerve root in her cervical vertebrae, which can result in radiating numbness or pain. And she was discharged with a prescription of naproxen and prednisone for pain management. 5 days later, she returned with no improvement with the medication, and pain and swelling that had progressed to her left knee, right thumb, right wrist, and bilateral ankles. Her initial lab findings were as follows: white blood count of 23,600, the SED rate elevated at 80, the CRP elevated at 76.6. The hospital ruled out autoimmune disease with a negative ANA and a negative rheumatoid factor, and ruled out Lyme disease with negative serology. Blood cultures that were drawn were also negative. An MRI was taken of her left knee, which revealed moderate effusion, fluid in the knee joint, and surrounding swelling. Arthrocentesis was performed to remove the excess synovial fluid and sent to the lab. The synovial fluid had a white count of almost 37,000 and was plated on blood and chocolate agar, incubated at 37 degrees Celsius with the chocolate agar at 5% carbon dioxide. However, both plates showed no growth. After 1 week, the patient left against medical advice for a second opinion. This is when the patient presented at the current hospital, at which point the Department of Rheumatology was consulted, and they recommended chlamydia and gonorrhea testing. So a urine sample was sent to a reference lab for nucleic acid amplification, and they empirically treated what they suspected to be a septic arthritis with azithromycin, ceftriaxone, and clindamycin. The Department of Orthopedics was also consulted, and they recommended a repeat of arthrocentesis, even though she didn't have a fever, because the knee was still swollen, and they performed a cell count, a gram stain, and culture. The synovial white count was even more elevated at 48,120 cells per microliter, and the differential revealed 89% neutrophils, suggesting bacterial infection. The gram stain showed intracellular gram-negative diplococci, as seen here. Less than 24 hours later, there was growth on the chocolate agar, and the bacteria that was growing was identified with a number of methods: enzyme detection, it was oxidase positive, catalase positive, carbohydrate utilization test, and it was only positive for glucose, and an antigen detection test for confirmation. 2 days later, the chlamydia, gonorrhea, NAAT came back positive. So her final diagnosis was disseminated Neisseria gonorrhoeae infection, which caused septic arthritis. She was treated intravenously with ceftriaxone, which was followed by oral antibiotic therapy. Her knee was rehabilitated with physical therapy, and she was discharged after a 3-week hospital stay. Neisseria gonorrhoeae is the 4th most common sexually transmitted infection in the U.S. and 2nd most common bacterial STI. Less than 1% of cases lead to dissemination. Women are at a 4 times greater risk because they are typically asymptomatic. It is, however, the leading cause of infectious arthritis in sexually active young adults without pre-existing joint disease or trauma. The symptoms include migratory arthritis, fever, skin lesions in 40% of cases, and there are other causes of septic arthritis. So the diagnosis is differentiated by the involvement of distal joints and having a reduced synovial white blood count, which, although you would think the 48,000 white blood cells is elevated, but it just is not as elevated as you would see in other septic arthritic infections. So the delay in this patient's diagnosis led to a significant joint impairment and a lengthened hospital stay. So what went wrong? Disseminated Neisseria gonorrhoeae should always be considered in sexually active young adults due to the prevalence of the STI and that it is the leading cause for arthritis in young adults. But the patient history account may have misled clinicians. She denied sexual activity, and she had just traveled to Mexico, which could have led them down a wrong path. But the elevated white count and differential in her CBC and synovial fluid did point to a bacterial infection, so it should have been followed up by the first hospital. But Neisseria gonorrhoeae is fastidious. It's prone to drying and temperature change. There could have been a delay or mishandling of this first synovial fluid. Blood cultures that were taken would be negative because the SPS anticoagulant inhibits Neisseria growth, and the gram stain and the culture are not as sensitive as the nucleic acid testing. Gram stain is considered less than 10% sensitive, and the culture is considered 50% sensitive. You might ask why like a media like MTM that is for Neisseria gonorrhoeae wasn't used, and it's typically used to isolate gonorrhea from sites with normal flora, so usually the genital sites. My source was a journal from the Journal of Clinical Microbiology. It is a great resource. It was inspired by a case that I heard while doing my rotation in micro. They just didn't have enough clinical information to make it interesting for you guys. So I hope you enjoyed and have a good day.